adesso passiamo a una relazione che sarà in inglese perché la relatrice viene dall'Australia. So, hello Danijela, it's my pleasure to welcome you. Danijela Gnijdic is an associate professor at the School of Pharmacy, Faculty of Medicine and Health of University of Sydney. Danijela is an expert in pharmacology and deprescribing, and she has had several substantial roles in the Australasian Society of Clinical and Experimental Pharmacologists. She is chair-elect of the Geriatric Pharmacoepidemiology, a special interest group of the International Society of Pharmacoepidemiology, and she will give us a presentation on what evidence do we need to deprescribe in clinical practice. So, Danijela, the floor is yours.
Thank you very much, Ursula, and thank you firstly for the invitation and for the introduction. I just wish my Italian was a little bit better so I could understand that very first presentation, but hopefully I could get some key points, and hopefully this talk will nicely sort of fit into the, I guess, some of the challenges in terms of geriatric pharmacology broadly, but really how do we see deprescribing in terms of informing clinical practice, evidence-based medicine broadly as well. I hope you can see my slides from this end and you can hear me well. All good?
Yes, we can.
Okay, perfect. So in terms of, I guess, what deprescribing is, this is some of the very first concepts that we proudly like to advertise to say it's an Australian word. And indeed, deprescribing was first mentioned in an Australian context by one of the colleagues and physicians, Michael Woodward, who actually proposed deprescribing as one of the potential solutions to achieve better health outcomes for older people through reducing medications. And since 2003, efforts have really grown to understand what the role of deprescribing is, how do we go about defining deprescribing, and I guess what are the clinical benefits of deprescribing medications, and specifically in older individuals where we often see that balance of benefits versus harms can be often unbalanced in terms of the benefits observed from these medications and obviously leading to increased risk of harm. But I think it can be argued that deprescribing is the process of withdrawing drugs in an attempt to improve patient-related outcomes overall. So I guess, thinking about the evidence so far and what evidence we have and what evidence we really need to inform our clinical decision-making, we recently tried to put together some thoughts around a deprescribing field broadly, as in what do we know and where to next. And I would like to use this opportunity to acknowledge my colleague, Emily Reeve, who is a pharmacist here in Australia. And when we put this commentary together, we really focused on what evidence do we have in terms of harms and benefits of deprescribing. And to date, a lot of efforts has been focused to inform the evidence behind deprescribing specific drug classes or individual classes. We do have increasing evidence on understanding what barriers or enablers are actually present in embedding deprescribing in everyday practice. And that often goes from the healthcare professional point of view, patient or consumer, or the setting broadly, or the fact that we have limited I guess, resources sometimes to roll out many of the multidisciplinary deprescribing interventions, which are often needed in practice to lead to successful deprescribing. We also need, I believe, better systems to educate multidisciplinary healthcare professionals at all stages of training to deprescribe. And so, for example, we've done some work here locally where we looked at what risk factors and what important aspects of deprescribing are often, I guess, seen as challenging by our healthcare professionals. And again, in early stages of training where trainees across all stages may not be as empowered to actually routinely think about deprescribing medications, but obviously with the extensive training and empowerment to do so, that is often seen as a positive sign to actually embedding deprescribing in everyday practice. And I guess all of these things together combined will actually enable those clinical decisions around deprescribing. So I think collectively, we do definitely need to do more work in terms of informing harms and benefits of deprescribing, but also thinking about practical solutions in terms of how can we actually embed deprescribing in everyday clinical practice. So if we're thinking about deprescribing broadly and trying to make sense of the evidence that we have so far to implement deprescribing routinely into clinical practice, I think to date, efforts have broadly focused on firstly determining the benefits versus harms of deprescribing specific drugs. And I'm here just attached and showcase some of the Cochrane reviews, which obviously are gold standard in terms of determining that evidence of benefits versus harms. So we've done a Cochrane review recently, which are currently going to be updated as well, looking at stopping antihypertensive drugs in older people. And what we identified was that in 6 trials of approximately 1,000 people, it was feasible and possible to stop antihypertensives, but really the benefits in terms of clinical outcomes was unclear. So again, showcasing the need of further work needed in this space to determine and aid those clinical decision-making. Similar to our Cochrane review, another Cochrane review focused on withdrawal versus continuation of long-term antipsychotic drug use for behavioral and psychological symptoms in older people with dementia. And again, what this Cochrane review showcased that it was feasible and possible, and in fact, appropriate to stop with these medications without major changes in terms of these symptoms. However, the sustainability of these, changes over time was unclear, and again, something that we needed to focus on if we are going to be routinely implementing deprescribing into practice. In terms of additional sort of making sense of the evidence, we do have also Cochrane reviews that are looking at interventions to achieve deprescribing of specific medication classes. And again, I'm here just showcase some examples. So we have a Cochrane review of pharmacological interventions for benzodiazepine discontinuation in chronic benzodiazepine users. And again, this Cochrane showcased that it is feasible, and pharmacological interventions are often successful for benzodiazepine discontinuation. We also have interventions for the reduction of prescribed opioid use in chronic non-cancer pain, again showcasing the success of some of these interventions, and again sustainability of these interventions being questioned in some settings, and showcasing the need for those further research in this space. And lastly, in terms of trying to make sense of the current evidence that we have in deprescribing space, is that a lot of focus has been shifted on interventions, or trying to identify interventions which to an extent include deprescribing activities as part of reducing polypharmacy or improving appropriateness of medication use broadly. And this is just one example of that Cochrane review, which looked at various interventions to improve the appropriate use of polypharmacy for all people. And again, this review showcased the role and importance of multidisciplinary interventions, which are often needed to ensure appropriate use of polypharmacy, but also in terms of experiencing prescribing benefits as well as clinical outcome benefits. So that is broadly the, gold standard evidence that we have with respect to deprescribing through showcasing examples of Cochrane reviews. But in addition to trying to understand what benefits versus harms are available in terms of deprescribing, efforts have been also focused to generate deprescribing guidelines that are drug focused. And today, most of this work has been done by our colleagues in Canada, who have done a fabulous job at firstly developing methodology that is validated in terms of trying to generate clinical practice guidelines, and appropriate resources in terms of trying to implement these guidelines into practice. And to date, they have developed 5 different guidelines that focus on these drug classes listed on the slide, including proton pump inhibitors, antihyperglycemics, antipsychotics, benzodiazepines, and cholinesterase inhibitors, and memantine. And to advance this body of work, we here locally were really interested to see whether there was a scope to develop deprescribing guidelines for opioid analgesics. And this stems from the fact that overprescribing of opioid analgesic is not just really a problem that we see in Australia, but it really is a major international public health problem that has showcased that in terms of opioid overuse and misuse, and most notably being present in the United States, Canada, and as I already mentioned, Australia. We also know that there are really strong harms in terms of associated with long-term opioid use. And on the other side of the story, we have limited evidence regarding the ongoing efficacy of opioids for chronic pain. So to try to address some of these issues in everyday clinical practice, we put together a core team of 17 multidisciplinary experts. And I do want to use this opportunity to acknowledge Ailey Langford, who's a PhD student in this project, who has led this as part of her PhD, and my colleagues, Dr. Carl Schneider from School of Pharmacy here at the University of Sydney, and Professor Christine Lin from the University of Sydney as well. To sort of address this question, we will often ask, why do we actually need opioid deprescribing guidelines? Because in Australia, and this is sort of similar to efforts internationally, we have had significant efforts to try to generate resources for consumers, patients, and carers and healthcare professionals to try to tackle this this issue of opioid overuse. But however, none of these efforts actually have been driven by, I guess, gold standard approach or validated approaches, and are often based on expert review approach or opinion-based approach. So to address this issue of opioid overuse, we did this process of developing evidence-based clinical practice deprescribing guidelines, and really to try to showcase how can we actually go about implementing these guidelines in adults taking opioids for pain to mitigate long-term use as a first step, obviously, and obviously moving forward any of the long-term outcomes that we tend to observe in these individuals. So just broadly in terms of the guideline scope, our goal was to provide recommendations on when, how, and for whom opioid deprescribing should be considered. I should flag that this guideline does not provide advice on when opioids should be started. And when we started our conversations in terms of the scope of the guideline and the target population, we felt that we really needed to keep this broad, because in order to capture the, I guess, the highest population of individuals that could benefit from these guidelines. So we decided to capture adults over the age of 18 years and over that are prescribed one or more opioids for any type of pain, so acute, chronic, cancer related. And we focused on primary care as a target setting, but obviously some of the recommendations that are going to come out of this guideline may be also relevant to other care settings. And within the Australian context at the moment, we're having a lot of issues in terms of overseeing opioid use at transitions of care, so from hospital post-discharge to community or to primary care physician. So there's clearly a scope to try to implement some of these recommendations in that context of transitions of care. So we just actually wrapped up our public consultation process, and we actually had to address quite a few opinions and submissions. So it attracted a lot of attention from various stakeholders, healthcare professionals, the government bodies, Department of Health, as well as consumers. And at the moment, we just submitted our guideline, and we're seeking approval from the Australian National Health and Medical Research Council. But at the same time, we're also thinking about proceeding about developing implementation toolkit. And this is aimed both for healthcare professionals and consumers, because we recognize that no one's going to be reading a 200-page document in terms of how to actually utilize this guideline in their everyday practice. And with that in mind, we teamed up with our colleagues in Canada who have had successful track record in developing various resources. And we are now in the process of finalizing some of these resources. And this is just an example of a resource or implementation toolkit that we will be developing that's aimed at healthcare professionals in the first instance, and then consumers. And you can really see that we're trying to showcase some of the key points around, what are the opioids? Do we need an opioid used for a specific type of pain? when is it appropriate to stop an opiate and how to go about it safely. And this will be followed with some of the really strong rationale behind how to go about initiating deprescribing plan, and actually how to go about following and monitoring that deprescribing plan over time and providing clear guidance on those steps. Obviously, very happy to talk to anyone about this work, and if anyone is interested to talk about potential for adapting these guidelines and recommendations. And in fact, we are currently working with a group in Canada who are very keen to actually adapt these guideline recommendations to a specific patient group, and in fact, seniors over the age of 50 and over, because there's clear relevance that some patient groups here are at higher risk of opiate harm, and as such, clear need to tackle those patient groups first with respect to initiating deprescribing plan. So, and I guess if we think about the efforts then today in terms of deprescribing specific drug classes or initiating, developing different guidelines to aid implementation of deprescribing, I think there's a clear need that we need to think about, be bold here and think about, our change in terms of how do we go about implementing deprescribing in clinical practice, because it is not always that obvious in terms of how to go about this process in everyday practice. There is this issue around, is it just a too hard basket to go about it? And often we think about implementing deprescribing into practice and reducing medications overuse as a wicked problem. And I think it will definitely require multidisciplinary wicked solutions, if you like, to resolve these issues. And I think to start that, we need that strong, robust clinical data in terms of safety and efficacy of stopping medications to embed deprescribing into practice, but to also empower our clinicians and healthcare professionals, as well as our consumers and patients, to trust in that process of implementation of deprescribing into practice. And I think to date, perhaps there was some confusion with respect to how we went about conducting deprescribing research, and perhaps that somehow reflects the current challenges in terms of implementation of deprescribing into practice. So if we look at the evidence over the last 10 years, we do have lack of consistency in the definition of deprescribing, and that, if you look at different deprescribing trials, in some studies, it's looked as complete cessation. In some studies, we look at dose reduction. In some studies where we evaluate the effects of therapeutic drug class or stopping therapeutic drugs, we often stop one drug class within that therapeutic category, whereas we continue other drugs. There is lack of consistency in interventions and outcomes that we report in high quality clinical trials, deprescribing trials, and that may have led to confusion as well. And broadly, there's lack of consensus on outcomes that we should be evaluating in deprescribing studies. So should we be focusing on prescribing outcomes, or should we focus on clinical outcomes, or should we focus on both? And how common, or I guess how different these outcomes should be from prescribing studies broadly as well. And I guess to what extent these deprescribing outcomes should align with the outcomes that we use to study drug efficacy and safety. But I think we could also ask this, question to say, well, if we do have some really good evidence that medications are associated with harms, for example, benzodiazepines and increased risk of falls in older people, then should this be enough to support implementation of deprescribing into practice? Or do we actually need more deprescribing trials to further back up that evidence to, again, empower implementation of deprescribing into practice? And I am actually pleased to see that a lot of groups internationally have started thinking about this and started focusing about outcome measures or recommendations that we need to think about for deprescribing intervention studies broadly. And just recently, there was a study published in Journal of the American Geriatric Society, which talks about how do we synthesize this evidence and what recommendations we need to put forward for future studies to have a synergistic approach for generating evidence. So in terms of deprescribing intervention in medication outcomes, is it number, is it quantity, is it dose, and so on. Then if you think about clinical outcomes, should we focus on function or treated signs and symptoms or quality of life or adverse drug withdrawal events and so on. And in terms of implementation strategies, what are those implementation outcomes that we need to focus on to better help, to help us understand how we can routinely implement deprescribing in clinical practice. And as Ursula mentioned, I am currently the chair-elect of the Geriatric Pharmacoepidemiology Special Interest Group, and we put together a manuscript proposal last year to the ISPE Society to work on this concept of trying to develop a framework to address methodological issues and to guide the design of observational studies of deprescribing using real-world data. And it's nice to see that we're coming from a different angle here in terms of how we can utilize real-world data or observational studies to arrive at some of those similar decisions that we flagged in the previous slide in terms of deprescribing studies. And we just really started to focus on this work where we're wrapping up a first step of systematic review, and hopefully the next couple of months or early next year, we will have this framework to, to discuss within the ISPE community, obviously, but broadly in terms of gaining some of the understanding and I guess what are the key aspects of methodological issues that we should focus on in this space. And with that in mind, I do also want to flag that there are efforts within other current groups to actually help us understand the role of deprescribing, standardize our approach in terms of informing the evidence, and obviously subsequently informing the sustainability of deprescribing clinical practice. And we just work with Cochrane Sustainable Healthcare to have a special issue on deprescribing to firstly flag what evidence so far we have within the Cochrane space in terms of this issue, and then moving forward, where do we need to focus our efforts, and clearly, I guess, coming up with a framework to provide some a clear direction in terms of how we go about conducting Cochrane deprescribing reviews with respect to, how do we define deprescribing with these reviews, and then how do we actually formalize that evidence in terms of clinical practice. And just lastly, before I wrap up, I am part of the Australian Deprescribing Network, and we always welcome colleagues, collaborators interested in deprescribing research. So please reach out to us via this website or on Twitter. And really hope, we like to actually talk about different issues that are present across different settings, different countries, and talk about common solutions in terms of tackling this important and really clinically relevant question. And lastly, I just want to wrap up by acknowledging the funding and obviously the collaborators along the way who have helped and assisted with this body of work. And if anyone is interested in doing some research or contributing to some research to deprescribing, we are currently just finishing off this study, which is looking at deprescribing antihypertensives for people living with dementia. And if you are a prescribing clinician who's treating people living with dementia, please do reach out to us or just scan this code here and help us understand some of these common challenges that we tend to observe in clinical practice. So thank you again, Ursula, for the invitation, and I'm very happy to take any questions.
Thank you very much. Thank you, Danijela, for this very informative and inspiring talk, because we learned some of the points we just can look at evidence before. And I think it's very important to keep in mind that deprescribing does not only concern the elderly, but as you showed in the opiate example, this may concern the entire population. So let's not only talk about the elderly, even if the elderly may be one of the main target groups. We will be very happy to follow up the activities of the ISPE and the manuscript you announced and all the other activities. And now I open the floor for questions.
Thank you.
Thanks a lot, Danijela, for this brilliant presentation of information. If I understood correctly, you also highlighted that the prescribing of antihypertensive drugs in the end, experimental studies did not provide robust evidence on when and how to implement this. The feeling I have is that for instance, we think about antihypertensive like using elderly people. Scenario will be very heterogeneous. Some patients may take more than one antihypertensive. So it may be very difficult to generate an evidence that fits for all. So we probably need to further identify subgroups that may be eligible for the prescribing. But I perceive that there is a lot of definitive generated evidence supporting evidence-based systematic prescribing, for instance, for drug classes like antihypertensive. So we'd like to hear your comment.
Thank you. I think I heard bits and pieces of the question, but I understand the question is around antihypertensives and deprescribing. And I agree that it's really hard to mimic in deprescribing studies what happens in the clinical practice. And interestingly enough, when we did that Cochrane review of antihypertensive deprescribing studies, we were focused on complete drug cessation, and we only could find 6 studies that did that. But in fact, if we looked at other studies where patients used other antihypertensives and they just stopped one of those, it would be interesting to see what the difference would be in terms of the findings. But this is often what the challenge is when you try to mimic and take the evidence from these studies into clinical practice. There's always a mismatch, if you like, between the real life setting and what we find in studies across.
Altre domande?
Posso fare una domanda io?
Certo, prego.
Good morning. I try to ask my question in English. Sorry for my English is not really good. Anyway,
It's better than my Italian, so go ahead.
thank you for your patience. I think that one of the most big issues in the prescribing is when in the patient story is this action to be done. I mean, which is the best moment to do this, to reflect about the need of all the drugs that patient is taking at that moment, just when an adverse drug reaction occurs, or in specific moments, for example, when the patient changes the setting of care, going back home from hospital, for example. What point are we now the research about this issue? Thank you.
Thank you, Marina, for that question. And it's a really valid point and a really challenging issue to tackle. I think broadly, situations when we should consider or warrant deprescribing is to say, well, when goals of care change, when symptoms versus preventive medications, when patients actually prefer to maintain their quality of life versus maintaining their disease state. We had similar challenges when we talked about these opioid deprescribing guidelines. Well, we then said you should start deprescribing implementation plan at the point of initiating medication. And that could be just a gentle nudge to say, you prescribe this medication now because it's appropriate within the context of your clinical scenario, if you like. But maybe in a week or 2 weeks or 2 months, that might change. You may not need that medication anymore because you might be started on other medications or you might develop side effects to it. So we should actually then actively think about or be proactive about implementing that deprescribing. That all requires extra effort from healthcare point of view, engagement, and it's not always that simple. But I think broadly, if we can say, always talk about it when you prescribe the medication, when goals of care change, and obviously, disease state syndrome, and broadly symptoms as well change as well.
Thank you.
Thank you. Other questions? Altre domande? Well, that's not the case. So Danijela, I really thank you. This was a very nice talk, and we really appreciate your availability to connect remotely. So if you like, you are invited to stay with us, even if now it goes on all in Italian, so it might be a little boring for you. So if you want to take off, we fully understand, and thank you again.
Thank you, Ursula, and all the best for the rest of the meeting.
Thank you.